cognizant of midfoot pain because this is missed so much, and the time to diagnose it is usually in terms of months instead of right off the bat when it occurs. And can you not hear me? Can you not hear me? Okay. So I'm going to briefly go through the history, but primarily these are all, in the literature, it's either cases or case series. And Bateman was the first one to describe it in greyhounds. Talked about the broken hock on the outside leg.
Okay, well.
It's killing me, John.
No, I'm just saying that they changed the structure,
Okay.
so if you would get on to this, there's a link I can send you, and this John Stroud guy will have his new password, and you can log on as long as you download the program or whatever.
Okay, Brandon, I hope you can hear me now. I'm sorry. So Bateman was the first one actually to really bring this to light, but it was in greyhounds, not the bus that you saw on the previous slide. Then Town just put it in the literature in the 1970s, just two boys in their teens. Torg is the one that primarily has written the most about this, but you'll see that he has fallen out of disfavor later on from 1982. Anyway, he presented 21 cases and really basically said treat them non-surgically. Finch said to operate on them. Kahn gave us the endpoint, and Saxena really gave us description in the literature for classification. But there's lots of series. Also in history, there's two meta-analyses that are available. One's by Torg, one's by Mallet. Torg again said not operate except for one that's maybe displaced, and then you should operate on that. Mallet talked about if you operate on them, they get back to sports a little bit quicker. There are less complications, and if you're going to treat them non-op, it's better to be non-weight bearing for 6 weeks. And in his meta-analysis, he described a lack of randomized controlled studies and also comparison studies. And he really didn't have any advice on how to treat them. Torg's meta-analysis was mostly case presentation type things. So the problem, and I'm going to be harping on this, is the positive symptoms, vague complaints, and the difficulty to actually see it on a dadgum x-ray. And so you have to have a high index of suspicion. Most of these people are going to present with midfoot or ankle discomfort, maybe even what some people would call tendonitis. And the most recent one I had presented as tendonitis for 3 months. There's no actual obvious pathology. A lot of times their muscle strengths and ranges are basically normal, and I'll harp on that as well. And so when we talk about the navicular bone, it is actually the rigid connection between the hind foot and also the forefoot. And the medial, and it's also a junction for the medial longitudinal arch as well as the transverse arch. And those are very active arches. The three distal cuneiform facets, if you, where's that pointer here? When you look at them, the medial half is really occupied by the medial facet of the, medial cuneiform, and then the lateral half is involved in the rest of the forefoot. The articular surface for the navicular, for the talus, actually is the one that controls the hindfoot motion of both eversion and inversion. And of course the medial tuberosity, which is a big part of that medial side of the navicular, is occupied by the posterior tib. The posterior tib artery actually comes in through the posterior tib insertion, and then you have the dorsalis pedis artery, which comes into the lateral side, but also goes underneath. And then the vascularity is actually really good in the medial third and lateral third, but in the central third, it's sparse, to say the least. And when you look at the biomechanics, the medial side of the foot is pretty active. The range of motion for the first ray actually is about 20 degrees. And then the next two rays, the second and third, are pretty rigid. So there's a lot of stress that goes through there. So you get actually, it's kind of interesting, when you look at the medial side of the navicular, when you have the first ray is here, and then the other two rays are over here, this stress reaction actually, or the stress fracture itself actually goes between those two rays. And that's where the vascularity is decreased. This between the facet of the medial and the facet of the middle cuneiform. But anyway, so you get a lot of stress shear across the mid-third of the navicular. The second metatarsal and the medial cuneiform are in that area, but the break usually occurs between those two. It's a longitudinally directed force, and it goes, again, splitting that avascular central one-third zone. So you get stuff like metatarsal adduction and pronated foot, but also just plain weight bearing and even lift off or push off causes stress. Now, one of my buddies, Harold Kitioka, did a big study on this, and I forgot to put where it was published on here. I apologize. But basically, it was an axial load study, and the contact stresses are the greatest in that central third of the navicular. In his cadaver study, he actually cut the medial longitudinal ligament, and it increased the forces through that area. So the rigid foot, according to Bob Anderson and Bruce Cohen, actually has poor shock absorption. These people are prone to stress fractures. And you see people with cavus, cable varus, metatarsal adduction, tight heel cords, prone to these. I'll be honest with you, in the last three that I've seen, they pretty much had a neutral foot. And so the big problem that we see, again, I'm going to harp on this, is the delay in diagnosis. Usually somewhere between 4 to 7 months, you get symptoms before actually diagnosis. And that's usually due to ill-defined complaints of soreness, cramping. And it's usually in the basketball, track, soccer, gymnastics, football, and rugby, but it can occur in anything. And I actually see it in people that participate in marathons or here lately, triathletes. Again, the symptoms are insidious. And it's interesting that they're at the beginning of the activity, let's say the running activity, and then it kind of goes away. The pain the discomfort will go away, and then it crops up again then at the end of the activity. And between whatever they're doing, if they're sitting out waiting for another track event or they're after a football game, there may not be any discomfort at all. They're walking around and have no discomfort. But actually the problem is that they will gradually get worse. So the idea is to try to catch this early. The misdiagnoses are these, really a midfoot sprain. Usually I think that when I think of midfoot sprains, I think of Liz Franks, but here, midfoot sprain, posterior tib tendonitis, anterior tib tendonitis, sometimes plantar fasciitis, ankle sprain, and Kohler's disease. Now, I bring up Kohler's disease, but I'll be honest with you, I only see that, I've only seen it, I think the oldest person I've ever seen that in is a 6-year-old, and I think they occur somewhere between the ages of 3 and 6 years old, but they're not, it's not very common, and it's probably self-limiting. So you got to be really aware of this. Now the end spot, that was given to us by Kahn, and it actually was between the extensor hallucis longus and the anterior tib, and that place right there where it says end spot. And if you touch the navicular there, it can be tender. I like to use a tuning fork, but you can percuss the navicular there and it will also be tender. And these people will also have pain with hopping or plantar flexion, forced plantar flexion, and they will have minimal swelling, and usually will have normal range of motion and strength. Imaging, that becomes the crux of how to diagnose this. And like I said, I'm harping on these symptoms, and that's the vague clinical presentation. It's insidious. It's usually with a jumping, running sport, and then maybe a tender navicular if you can pick it up. Got to be aware. This is delayed diagnosis, those vague symptoms, poor awareness, and the x-rays are normal in at least a third of these cases. It's important to pick this up because the poor outcomes associated with delayed union, non-union, chronic pain, and not being able to return to a pre-injury state of activity. So the earlier diagnosis, the less the morbidity. And here actually is a patient that is mine, and they had midfoot pain, and this is a x-ray of their navicular. We did get weight-bearing x-rays first, and then we decided we couldn't see that navicular good enough. So the plain weight-bearing x-rays, poor sensitivity. In Kahn, he had 86 of the 126 cases that he reported on had positive x-rays. So a third of these really did not have any x-ray changes. The higher the incidence, the more incomplete, there's a higher incidence of negative x-rays with incomplete fractures. And we really don't start seeing fractures until there's osteoclastic resorption at the fracture site, particularly with these. And it's very difficult to get that true AP of the navicular. Now, triple phase bone scan is actually pretty sensitive. It's like 100% sensitive, and it's going to be positive in all three phases of the bone scan, like it is on this one. Unfortunately, the specificity is poor. So if you have a negative test, it actually excludes the diagnosis. So if you get triple phase bone scan, it's negative. They don't have it. If it's positive, then you have to see what's going on in the bone. So you're going to have to at least get a CT. And if it's negative, you may actually end up having a stress reaction. We'll talk about this a little bit later as well. So it helps, but it's not the cigar. So it's very good with bone metabolism abnormalities, which would include acute fracture or stress accessory navicular. A tarsal coalition will be hot, anterior tib, and also posterior tib may be warm. And also tumors and osteomyelitis will show up on positive on the bone scan. So to get the precise diagnosis, you need something else. And here we have a triple phase positive bone scan, and then we have the CT showing the x-ray. This actually is a type 2 fracture. I'm going to talk about that. So CT scan. CT scan actually, when the bone scan is positive, CT scan is negative. That does not rule out a stress reaction of the talus, of the navicular. If the bone scan is positive and the CT scan is positive, and you can see it here again, here's the type 2 you saw previously, type 2 fracture there on the on Ural's right. So the best to show this is the axial and coronal images. And it's usually, again, in the proximal 1/3 of the navicular. So it's going to be high, and it's going to be in that center fold avascular area. And so in this case, it does not go through the other cortex, but it does go into the body, which means that this is a type 2. The fracture usually is oblique, and it's dorsal medial to dorsal plantar. Here's again, it's a CT is effective in diagnosing the stress fracture, but it's not effective in diagnosing stress reaction alone. In the X-ray on your left, the two films on your left, these two, this is a case of mine that had a positive bone scan, but a negative CT. And so the CT classification was given us by Saxena, and he reported his findings, and I think these are based on 22 cases. And type 1 is a dorsal break in the dorsal proximal navicular. Type 2 is a break, but the fracture just goes into the body and does not exit into another cortex. And type 3 involves another cortex. And this scheme is modified with avascular, cystic, and sclerotic denotations as well. And the importance of this classification is it gives you typing of the fracture, and it gives you a time and outcome back to activity. So it's important to know the classification. And so to this, we should probably add stress reaction. And again, we'll talk about this in just a second. Matter of fact, we'll talk about it right now. So the stress reaction may be present prior to developing an actual stress fracture itself. And this is an MRI. And this denotes the bone marrow edema, and we see the abnormal signal. And it's actually hyperintense on stir or water weighted. The edema is actually centered in the proximal dorsal navicular, and that gives you the hint of that's what's going on. And here it is again. This is my case itself, where this is actually a stress reaction. You get marrow edema, you get an ill-defined signal in the navicular itself. And it's hyperintense on water weighted, and you get edema in that center portion of the tarsal navicular itself. Again, on that previous slide, there's no fracture on the CT. This patient, by the way, was a high-performance high school athlete. Is a woman. She is quite tall, and she's already being recruited as a sophomore by Division I schools. And she came in with a 3-month history of tendinitis in her foot. And actually, at this point, when I got this MRI and CT, she was limping. So type 2 fractures actually will go into the body. There's one cortex, and the fracture actually extends. Now, you can see this on this MRI, but if I didn't see it on the MRI, I would have certainly got a CT, because it just shows the bone detail very blatantly. Now, there are some variants that you have to be aware of, and this is one of them. And you get this incidental cleft, and you can almost see a little ossicle here. And the cartilage, though, in this CT is actually intact, in this MRI, and there's actually no bone edema. And so you see this actually quite frequently on regular x-rays. And so the question is that a prior fracture? Is it a remnant of cartilage rest cells or a developmental abnormality? Or are these people the ones that are prone to stress fractures or stress reactions? You just have to be aware. That's why it's important to check the stirs, especially for T2. So there's another abnormality too that you have to be aware of. And this was the image that I showed you, the one image I showed you here on the at the beginning of this talk. And you can actually see this line. But when you look at the T2, there's really no T2 stir, there's really no edema around this. And here it is again. On CT, you can see a little ossicle occurred right here. But there's no bone, marrow, or bone changes here. There's the ossicle. This ends up being a vessel. So you have to be aware of this. That's why you have to look at other CT images. You want to look at basically all the CT images. So the cost, a 3-phase bone scan. I'll try to get you guys to do this on your talks. So the cost of 3-phase bone scan at this institution is $2,900, or actually $3,000. The CT scan is $1,100, and an MRI is $2,800. And that does not include the radiologist's fee. It's pretty expensive. All right, treatment. This is ever evolving. So the non-operative crews have been really led by Joe Tord and Temple. He believes that all non-displaced fractures should be treated non-weight bearing 6 to 8 weeks in a cast. And he showed this in his 21 patients that he reported on, but he had 10 non-weight bearing, they all healed, and 7 out of 9 that were weight bearing failed to heal. But he did say that if this fracture was displaced, you should probably bone graft it and keep it non-weight bearing until it actually heals. Khan also was another big non-operator. He's the one that gave us that end spot. And he reported on 86 cases, and 22 of them were treated with non-weight bearing. And he had 86 of them actually returned to sports. 86% of them returned to sports at 5 to 6 months. And 34 of the 86 were treated with partial weight bearing for 6 weeks, and only 26% of them returned to sports. Then there's the operative crew, and that includes Finch. Finch was pretty aggressive. He believed that you should operate on complete fractures or comminuted, delayed unions that were treated non-surgically for 8 to 10 weeks in a non-weight bearing cast, or anything with a cyst. And he felt that with the unpredictable nature of healing in this fracture, an asymptomatic may heal or look healed initially, but may not actually be healed. The kicker on his was he believed in doing an in-block autograft with no internal fixation, which I thought was interesting back in 1989. So operative, Saxena, he reported 2 times. One gave his classification in 2000, and then in FAI 2006 reported getting them back sooner. So his first one, he had 22 navicular fractures, and with his classification, again, the more severe the fracture, the greater the time to full activity. And he documented that surgical patients actually return to activity much quicker than the non-surgical. And he believed that all type 2 and all type 3 should be operated on. His follow-up report gave us the return to activities where the type 1s really the type 1s and type 2s, actually surgical, non-surgical, were basically the same, but they actually got back going, because in the literature you see that to get these people back to a full activity, it's going to take somewhere around 5 months, 4 or 5 months. Now, Nunley out of Duke, I forgot to put his reference down too, is he believed in doing vascularized bone graft on these. So recurrence, what's the recurrence rate? Recurrence probably somewhere between 10 and 20%. And Byrne in 2005 reported on his recurrence. One occurred at 7 months and the other one at 18 months. And Saxena had 2 patients, and Torg in his non-op had 1 out of 10. And if you get a recurrence, Mann and Pedowitz say operate on all of them. So, in conclusion, high index of suspicion. Know what the end spot is between the extensor hallucis longus and the anterior tib. If bone scan's positive, you need to get something else. CT will show the bone detail better. But a bone scan will only be hot, but the differential on that is as seen up here in red. Tumor, osteomyelitis coalitions, anterior tib, posterior tib, acute stress fractures, acute fractures, stress fractures, and stress injuries. So if bone scan's negative, there's no fracture. An MRI, if it's positive, that's going to be at least a stress reaction versus a fracture, so you need to get a CT for bone detail. If a CT is negative, there's probably no fracture. But you have to get an MRI to really rule out a stress reaction. Or you could actually, I didn't put it up here, but you could also do it with a possibly a CT. A bone scan. But a bone scan, remember, shows metabolic activity. So the classification, stage 1, stress reaction. They'll piffer out into an actual stage 2 and a stage 1. Stage 2 is no actual crack, but the bone has been injured. Stage 1 has one cortex, and remember, it's dorsal, so you got to look high in the center of the navicular. Stage 2 will have the fracture propagate into the body, but will not go through another cortex. And stage 2 involves 2 cortices. And with the higher the stage number, the greater mortality and the greater difficulty in getting this to heal. So treatment, stage 0, stress reaction, 6 weeks non-weight bearing, and then rehab. Stage 1, 6 to 8 weeks in cast. If they don't heal, then operate. Stage 2, non-weight bearing 6 to 8 weeks. If it doesn't heal, operate. In a high-performance athlete or somebody that's got to get back going sooner, should strongly consider operating. Stage 3, probably should operate on all of these. And so if there's a cystic or if the fracture is displaced, you definitely want to graft it, and you definitely want to use internal fixation. So the information also you need to give to the family and also coach would be return to activity. And it's going to be somewhere between 4 and 7 months. And it's a gradual rehab. And what I use on the ones that I get, I use a short articulated AFO, progress them to foot orthosis. But I also have them during their rehab, or even if I'm immobilizing them, I'll have them start on at least intrinsic exercises. And that's it. Any questions?
Well, how do you deal with the patients who have got accessory navicular?
I'm sorry, ask again.
Accessory navicular.
Accessory navicular?
Mm-hmm.
Well, there are 3 types of those. And type 1's a round ball. Type 2 is like looks like a growth plate was there at one point. It's still there. And type 3 is a taffy pull. Basically, for my hands, I treat a accessory navicular pretty much like I would a posterior tib, where I would brace them. Sometimes they're real tender, I'll immobilize them. But usually I'll put them in a brace and I'll rehab the posterior tib. And with that, my success has been right at about 90%, but there's still about 10% of those that I will end up operating on. And the posterior tib, with the accessory navicular, I have a real conservative approach to it because of this. When you look at the accessory naviculars that have been operated on in the literature, you get about 10% of them that don't actually do very well and continue to have pain later. And so I'm pretty conservative with them for that reason. Yes, Pete?
You made a comment early during the anatomy and motion stuff. There's about 20 degrees of motion in the first grade. Is that at the navicular joint or the navicular grandfold joint? What plane is it?
It's a dorsiflexion, plantar flexion plane. But it's also there's a little bit of a rotation as well, where it rotates up and out, down and in. And that actually goes through that section of the, it goes through the medial cuneiform, and it goes then into the stress into the navicular itself. That is one reason why I will put these people in a short articulated AFO. I can actually control that, but I can give them motion until they get totally rehab for muscle strengths. And stress reaction, you can get away with a lot of things. I put my stress reaction naviculars, I put them non-weight bearing, but I'll put them in a short articulated AFO, and they'll be using that anyway when they go back to sport or whatever for at least the first part. When I have them treated, while I'm treating them, I'm actually putting them on intrinsic strengthening exercises and some general range of motion, but I don't let them load it other than to now I use a rolling knee walker where they'll get off the rolling knee walker and they'll do something, they'll get back on the rolling knee walker. But I don't let them really walk on it until it clears on an MRI. The stress reaction's gone. Mike?
So what is your preferred surgery for type 2 and 3?
Type 2 and type 3 would be probably bone graft and internal fixation. Although there's some ones that have been type 2 that have, if they have a cystic change, I'm going to actually bone graft them. If they don't have a cystic change, I'm probably not going to bone graft them. Here lately, my cystic changes, I've actually done some injections and done internal fixation and got them to heal. The last two I did that on.
Type of internal fixation.
Screw across it. And usually the screw is actually directed from lateral to medial. A lot of times you'll see where a screw is directed the other way, but you have to be really a bullseye on that screw because there's more for that thread to go through on the medial side than it is on the lateral side, than the navicular. It's a good question.
Partially threaded or?
Partially threaded. But if you didn't, you could do a glide with the 3-5. Depends how big the person is as well, too. We had, at the University of Vermont, we had a 7'2" NBA player that we used a 4-5 screw on. He had a size 26 foot. Yeah.
Do you base your decision of bone grafting based on the bone scan results?
No, based on whether it's a cyst or not, or displaced.
With the cystic, you'll bone graft it.
Cystic is recommended in the literature to bone graft. The last two I've done was I've fixed them, but I've also injected them with bone marrow aspirate and got them to heal. But now Nunley will tell you if there's a cyst, you do a resection, do a vascularized bone graft for this. Any other questions? That's it.